Afternoon and welcome to the New Jersey webinar series. Today's webinar will focus on an overview of New Jersey state epidemiology. We believe this webinar will be of interest to our regular audience of TB health professionals, as well as physicians and anyone else who would like to know more about TB surveillance in New Jersey. My name is Mitchell Gayer. I'm the Deputy Director of the Global TB Institute, and I will moderate today's webinar. The objectives of today's webinar are that at the end of the program, you will be able to describe the latest epidemiological trends of TB globally, nationally, and locally, and how it affects TB in New Jersey. You'll be able to explain the role of surveillance and how it relates to TB program performance, and understand the importance of accurately collecting data variables for the national database. Our speakers today will be Frank Romano, Program Manager, and Eric Cortez, Molecular Epidemiology Coordinator. Both of our speakers this afternoon work at the New Jersey Department of Health TB program. Today's conference will consist of two parts. After this introduction and some housekeeping details, Frank Romano will give an overview of tuberculosis statistics in New Jersey, and Eric Cortez will update us on recent trends in surveillance. We can have one or two questions after each speaker. In addition, we are setting aside 10 minutes at the end of the program for more questions and discussions with all of the presenters. It's probably better if we save our questions towards the end of the program, especially if we need time for the actual presentations. This program is being recorded. You will be listening to the audio through your computer speakers. If you do not hear any sound and you've confirmed that your speakers are on, you may need to dial in. You will be entering this conference in muted mode. Please keep your phone muted for the duration of the presentation. After the final presentation, we will have a period for questions and answers. To ask questions, you must first unmute your phone with your computer speakers turned off. You can unmute your phone by pressing *6. After your question, you will remute your phone also by pressing *6. Please introduce yourself and say where you are calling from when you ask a question. Handouts. Handouts may be downloaded from the slides, the sign-in sheet, and resources at the link listed on the slide. Please download the sign-in sheet and have everyone viewing with you sign it. Handouts are also accessible as a click-on link in the evaluation that was part of the webinar instructions email. To receive credit, you must take the online evaluation. The link is listed here and is also on the handouts page. Okay, so without further ado, Frank Romano will now give us an overview of tuberculosis in New Jersey.
Okay, hello. Is my audio good?
Yes, you sound good, Frank.
Oh, excellent, thank you.
I wonder how Frank likes to
Oh, I have to press this. Okay. I'm just going to share some data with you all today, and this is sort of a continuation or an update from what we did last year. Although last year was a little bit shorter presentation, it was more or less the highlights. I did request a little extra time this year so I could maybe delve a little bit deeper and share a little more information with all of you. So this was a slide that I had put up last year, and some of this, well, all of this information came from the U.S. Census Bureau, but we did find one mistake, so you'll see it on the first bullet, where I crossed out 6th and put the 4th smallest state, because actually, as it turns out, only Connecticut, Delaware, and Rhode Island are smaller geographically than New Jersey. But all the rest of the information is good. And so I just wanted to say, you know, kind of keep some of these numbers in mind, you know, 8.9 million people, essentially 50-50 female, male. And a big piece of this is that there's 23% of the population in New Jersey is foreign-born. Okay, and so that's a pretty big number. That's over 2 million people. some of these numbers just kind of keep in the back of your mind as we go through. Okay, so we'll just take a look at some case rates and trends in New Jersey primarily we'll be looking over the last 5 years. Occasionally we might be looking at 10 years, but generally it's going to be 5 years. Stand by.
No, it's my phone.
Oh, it's your phone.
I don't have,
Oops. Okay. I was having a little trouble changing the slide, but it's okay. So here is, oh, no, I just lied to you. I said 10 or 5, and here we go on over 20 years. But I just want to, really, you need to look at this trend line, you know, over a long period of time to really see the effects. So again, 1992 was the peak of the resurgence of tuberculosis in the United States. In New Jersey, there was some 984 cases back in 1992. Nationally, it was like 26,000 cases. Whoops. Back, hold on. So I just put in some data points there, and as we arrive at the end of 2014, which is the last full reporting year that we have, slide keeps changing. Stand by. It's almost like it's on a timer. Oh, well. Okay, so there's been a 67.5% decrease in TB since 1992. Okay, literally 2/3 of all the cases have been eliminated. And that's actually true nationally as well. Here in New Jersey, 36.5% decrease since 2005. That's the 10-year trend. And there's been a 24% decrease in reported TB in New Jersey since 2010. That's a 5-year trend. So you'll see here that in the last, in just the last couple of years, we've seen a little bit of a leveling off of the number of reported cases, where that decreasing trend is sort of halted a little bit. And we'll talk about that as we proceed. Okay, just looking at purely at the numbers, case counts over this was 2014. This is information that was published in World TB Day, MMWR. So I pulled these numbers out of here just to show you what's going on nationally. You can see that these 10 states here, New Jersey being among them, account for more than 2/3 of all the TB cases reported in the U.S. In last year. Taking a closer look at the New Jersey numbers over the last 10 years. This table shows the number of cases and the corresponding incidence rate in New Jersey. If we just focus on 2014, that there were 308 cases, and the corresponding incidence rate was 3.5 cases per 100,000 population. National average there is 3.0 cases per 100 population. So New Jersey is slightly above the national average. Okay, and then we'll take a closer look at some of the summary data. This is the data that we report to the CDC. Of course, this is all based on the information that all of you all provide to us here at the State Health Office. So I thought some of this information might be interesting to some of you, so let's take a look. Now, we use certain verification criteria. In general, we're talking about cases that are culture confirmed versus the clinical diagnosis. So what it's actually, this is about, it should be 81 and 19%. So 81, just shy of 81% of all the cases reported in New Jersey over the last 5 years have been culture confirmed. I actually looked to try to see if I could find what this looked like nationally, and I was surprised to find that this information was included in the last published national TB surveillance report, which was published about this time last year. So, but I do recall, and I don't know if I'm wrong about this, but I can remember years ago, we were doing case counts. I was in Louisiana, and I noted that about 80% of the cases were culture confirmed. And I sort of remember talking about it, and they said, yeah, that's usually the way it works out. It's usually about 80% culture confirmed, and we see about 20% or so clinical diagnosis. So I think this is sort of what we'd expect to see in New Jersey. And again, this is over a 5-year time period. We're looking at, over that period, we saw 1,665 cases reported by New Jersey. So remember that number too, 1,665. You'll see that number a lot. And just a little bit more detailed breakdown of that. We look at over the same time period, nearly half of all the cases were sputum culture confirmed, and then you had 30% of all cases were other culture confirmed. And then you see, I kind of lumped together the clinical and the provided diagnosis because those are surveillance definitions, but these are essentially cases that are diagnosed by physician and in the absence of laboratory confirmation. Okay, and again, so it's about 19%. And then we have this new category, relatively new category, which is nucleic acid amplification test confirmed, which accounted for just a small portion, about 2% of all cases reported over the time period. So again, that gives you an 81 to 19 split versus culture confirmed versus a clinical diagnosis, but just in a little bit more detail. Whoops. Just focusing in on just the culture confirmed cases, okay, you'll note that 2/3 of them, about 2/3 were from sputum, okay? That's the source. And then we had about, a third, a little bit more than a third who came from other tissue or body fluids. Now, some of these data categories may look familiar to you because, again, this information is taken directly from the TV70s that are submitted by you to this office. Okay, and then again, just kind of looking at the information in a very broad way. If you just look at it in sort of a dichotomous way, just pulmonary versus extrapulmonary, you'll see that over this time period, more than 3/4, 77% of all the cases had pulmonary involvement. Another 23% that were just or exclusively extrapulmonary. And of course, the world's a little more complicated than that. So we do have people who present with multiple sites of disease. So if you look at that second red box there in the legend, it really should say pulmonary plus at least one secondary site. I mean, some of these have multiple sites of disease. But again, just looking at all cases reported over the 5-year time period in New Jersey, again, 1,665. Right at 2/3 of them were exclusively or pulmonary alone, just pulmonary TB. And then you had a little bit of a mixture with some multiple sites, and of course the 23 that were exclusively extrapulmonary. Now let's take another look at that. Right now, we're just going to focus on this piece of the pie right here. This 23%. It's actually, I think it's like 23.4%. And so just keep that in mind. We're just looking at now. We're going to focus in on this just slice of the pie right here. These are your extrapulmonary cases sorted here by site of disease. And again, that was 390 cases observed over the 5-year time period. You can see that the most common site of extrapulmonary disease was lymphatic. And I put this number here because I wanted to, make it a point to mention this, that, again, this 155 cases, while it's 40% of all extrapulmonary, it represents about 9% of all cases reported over the time period. Okay, and the second most common site was pleural, and then we go into the bone and joint, meningeal, and the more rare forms of tuberculosis. Okay, another thing that we look at, from the statewide surveillance perspective is essentially where these cases are occurring. I mean, obviously we know it's New Jersey, but, TB is not distributed evenly throughout the 21 counties. We're always interested in to see what the geographic distribution of TB is. Now, if you've recently visited the website, we have this map up there, and this is a map that shows the incidence rate of TB in 2014. This is cases per 100,000 population per year, so it can only show 1 year. And these maps will change quite a bit from year to year. I mean, because a few cases more, a few cases less can sort of change, the numbers and change the corresponding color of your county or the county next to you quite a bit. But just for the sake of discussion, in 2014, you had the highest incidence occurring in Hudson and Middlesex counties, and then followed by Essex, Passaic, and Somerset. Okay? But again, it's always important to remember that incidence is only one measure of TB morbidity. And it would always serve you well to look at the real numbers. All right? So look at the actual case counts as well. That goes for everything you look at. Don't always just look at incidence, because incidence can be misleading. If you have a population that's very small in a certain county, and just a few cases can lead to a very high incidence or relatively high incidence. So this is a map that's not on our website, but here I just put in the case counts over 5 years and sort of came up with some categories. And you'll see that the highest numbers of cases were reported in 3 counties, Hudson, Essex, and Middlesex counties, who reported at least equal to or greater than 200 cases, followed sort of by a second tier of counties, Bergen, Passaic, and Union, that reported somewhere between 100 and 199 cases, and so on. You can see as the color codes cascade down. Now, what's sort of interesting about this, I thought to myself, well, I wonder what this would look like if I could overlay this with a population map, Admittedly, I'm not from New Jersey. I'm learning as much as I can about New Jersey. But because of that, I come in sort of with, open mind. I'm trying to find out, I think we have a sense that most people live up in the northeast section of New Jersey. Well, I couldn't overlay the map. I just kind of did this side-by-side deal. And it was pretty interesting to see how, if you look on that, I don't know if you can see my arrow, but this is sort of like the I-95 corridor here in the northeast section of New Jersey. And you can see that corresponding red, how it kind of almost lines up exactly with the red we see on the TB morbidity map. And even down here, like where Camden is, you see sort of a red area. And then that corresponds, of course, now we're shading the entire county, okay, based on the number of cases counted over the time period. And then even here along the coast, what do you call it, the Jersey Shore, and Monmouth and Ocean, you see a little bit population density along the coast, and sure enough, a corresponding, darker shade of, I guess that's pink. So I think clearly you could see that, we're seeing the most cases where obviously we're seeing the most population or the density of population, which again is what we would expect to see. This is a frequency table that I've created, so we can sort of take a look at the actual numbers by county over the 5-year time period. And you'll see again, Middlesex County had counted the most cases over the 5-year time period with 260, and the average 5-year average is 52 cases per year. Now, this table also includes this cumulative percentage, and if you just look at the top 6 counties listed here, you'll see that corresponds to approximately 70% of all cases counted in New Jersey over the previous 5 years. And you'll see that Passaic comes in at 121 cases, and there's quite a drop-off from there. Just to give you some sense of, you could look here, obviously, and see where your county is on this list. And hopefully you won't be too surprised. You should be at least generally aware of what these numbers look like. But if you're not, that's okay, because that's why we're here. And you can always call us and we'll share any information we have with you that we can. So again, 6 counties, Middlesex, Hudson, Essex, Bergen, Union, and Passaic, accounting for close to 70% of all cases reported over the 5-year time period. Okay. Of course, in any discussion of descriptive statistics, we need to look at the demographics of the case patients involved. And generally, it's going to be age, race, ethnicity, sex, or gender. These slides, I've just sort of recreated the slides that appear in the national surveillance report, just to sort of see how New Jersey lines up with the rest of the country. And you see, over the last, this is 10 years. Over the last 10 years, consistently, we saw the highest incidence rates occurring in the 25 to 44-year-old age group, and the equal to or greater than 65-year-old age group. And I'll tell you, now this is a little bit uncommon to see 25 to 44-year-olds with the highest incidence, but we'll see later on in this presentation, you'll see this is directly related to the foreign-born population. Foreign-born individuals from countries where TB is endemic, you know, who have relocated to New Jersey. Let me see. And again, just looking at those age groups a little bit closer, over the last 10 years, we saw 3,943 cases reported by New Jersey. Now, when you look at this slide on the national level, about 2/3 of all the cases appear in these 2 age groups, but they're more evenly split. It's about 31% here and 31% in the 25 to 44-year-old age group. So you see, it's a little bit skewed here in New Jersey. But again, I'm going to show you how there's a disproportionate number of folks who are foreign-born who fall within this age group of 25 to 44-year-olds. So really, it's the foreign-born TB numbers that really drive the data in New Jersey, and you'll see that if you watch closely, you'll sort of see that throughout this presentation. Just be mindful of it. I mean, there's other good things on here. You'll see that the pediatric age group, which is defined as individuals who are equal to or less than 14 years old, actually account for only a very small percentage of all TB cases reported over the last 10 years. You know, although the numbers, we'd prefer to see that 0, obviously. But so there are some encouraging things here as well. Okay. Also, this is another slide that's created, again, just sort of mimicking what's going on in the National Surveillance Report. And basically what they're saying here is that across all age groups, you know, males are disproportionately affected by TB. And in the national data set, in the pediatric group, it's actually even. But we see it's a little bit, it looks here like the female group is a little bit disproportionately affected by TB. This may just be due to small numbers, this age group. Because again, we're just looking at 1 year's worth of data here, because I'm using a rate. So I wouldn't focus too much on this, but again, you'll see consistently in all the data, whether it be statewide or national data, that it's males who are equal to or greater than 65 who are most disproportionately affected by tuberculosis. When we look at the rates of TB separated out by race ethnicity, and here I was able to put, you know, 10 years worth of data here, you know, plugging in the incidence rate for each year, you'll see that the highest rates occurred among the Asian population, individuals who are self-identifying as Asian. And I don't have the national numbers right here in front of me, but I believe it's also correspondingly high in the national data set as well. But you can see here, again, now if you just think about Asian, Hispanic, I mean, we're generally, not all the time, but we are in many instances talking about individuals who are foreign-born. Okay, so no surprise that we'll see the highest incidence rates among these 2 groups. Okay, when we look at TB reported cases here by race, ethnicity in New Jersey, again, over the 10-year period. Just looking at the real numbers here instead of rate, what you'll see is that 40% alone just are kind of Asian. Okay, and this includes East Asia, South Asia, Central Asia, and Hispanic, 31%. So when you combine those two groups, you're looking at over 70% of the cases occurring in Asian and Hispanic group. You might suspect that's related probably to foreign-born, but we'll look. We'll take a closer look here in a minute. Well, I guess I didn't see that coming, but with all the discussion of foreign-born, I thought it might be worthwhile to kind of focus in on the foreign-born group. Now, the thing you got to know is this: by the end of 2014, some 81% of all the cases in New Jersey were reported were foreign-born. Okay, so you really can't have a discussion about TB in New Jersey without some discussion, or perhaps even a lot of discussion, about the foreign-born. So we'll take a look at some of these data. All right, this is a real long trend line, again, some 20-something years. And there's all sorts of misconceptions out there. You will hear sometimes people talking about, well, you know, TB is on the rise among the foreign-born. Well, that's actually not necessarily true, because you got to remember that TB continues to decline in the U.S. In fact, by the end of 2014, there were only 9,412, I think, cases. So again, remember, that's something like 67% decrease since the peak of the resurgence in 1992. So this trend line goes back to almost 1992, but you can see that what's changed is that 20-something years ago, there used to be quite a bit more U.S.-born TB, represented by the blue line, and then, of course, foreign-born cases reported here, represented by red line. If you kind of fast forward to 2006, you can see that there was some 385 cases foreign-born reported in New Jersey. And that's, if you just follow that line there, you can see that the total number of foreign-born cases actually decreased quite a bit. Let's see if I have the actual number here. Well, and what did I write here? My note's a little bit messed up, but that's okay. But you'll see that with 385 cases here in 2006, and by 2014, we're looking at about 250 cases. I think that's, I'd have to do the math real quick on that, but I think it's about a 24% decrease. Correct me if I'm wrong, old minus new divided by old. It doesn't matter, but I just want you to focus in on this 2011 through 2014. You'll see these foreign-born cases here represented by the red line, they're really not increasing, but notably they're not decreasing either. It's almost as if New Jersey's leveled off here, about around 250 cases occurring among the foreign-born each year for the past 4 years. Now, of course, we have yet to see what our final numbers will look like for 2015, but this is something that we'll be watching very closely. You know, will we continue to see this sort of leveling off here? Another thing, and it may be on the next slide, but in 2013, there was actually a little increase in TB in New Jersey. It was like a 2% increase, I believe. And we went from 302 cases in 2012 to like 320 cases in 2013. But if you look here closely, you'll see that that increase was directly attributable to the U.S.-born. Yeah, the blue line's a little bit bigger in 2013. So the increase we saw really was not attributable at all to the foreign-born. It was the U.S.-born. And what we'll do here next is, I think what I did was, if you just look at, we're going to focus in a little bit just on the foreign-born, which again is represented here by the red bars. Okay, so this is New Jersey over the same time period. And again, oh, there's my number. So it was a 35% decrease in TB among the foreign-born between 2006 and 2014, right? With cases falling from 385 to 252 in 2014, okay? But, you know, what happens is when you hear people talk about, well, you know, the TB is increasing among the foreign-born. what they're talking about is that basically, if you look at the national numbers, and you put that into a pie chart, basically the pie is getting smaller, right? Because the number of the cases actually is going down every year. But it's the proportion of that pie made up by the foreign-born that is getting bigger, right? So if you sort of picture it that way, smaller pie, but more slices of foreign-born, right? And that can happen if the foreign-born cases, again, like we see here in New Jersey over the last 4 years, just stay level, and we continue to see decreases in the U.S.-born, right? So total number goes down, but the decrease, is because there's less U.S.-born TB, and essentially the same amount in number of the foreign-born. This is another thing that I wanted to look at for New Jersey. I was poking around on the internet and looking at the CDC's website, and the CDC actually published a report, and it's called the Recommendations for Prevention and Control of TB Among Foreign-Born Persons. It's dated September of 1998. So this is like 17-year-old data. But I was looking at it, because I actually created this slide, and then I started. It's kind of, you sometimes can't resist wanting to know the why. We talk a lot about the who, the what, the when, the where, right? But the why is a whole nother piece, which lends itself more to, let's say, inferential statistics or studies. But sometimes we can't resist. So I thought, well, I wonder why this is, that, a full 1/3 of these individuals progress to active disease within 5 years of entering the U.S. I went to the CDC to sort of look for some answers here, and they have a little caption. They said, most TB cases among foreign-born persons are likely the result of reactivation of remotely acquired infection, although some transmission is probably occurring in the United States. And then they go on to say that they've used RFLP genotyping to confirm that there has been some transmission to the foreign-born by other foreign-born people in the U.S. Other studies documented high percentages of cases among children of the foreign-born. Keep that in mind, because we're going to talk a little bit about that later on. And other studies document high percentages of for all immigrant groups. It goes on to say, for all immigrant groups, the disease risk appears highest in the first years after arrival in the U.S. Among some groups, the risk decreases rapidly over time, whereas for others, it remains high for up to 20 years. Now, at the bottom of this slide, I put here like the median time, from arrival to diagnosis of disease was actually 9 years. But you can see the range is quite big, and so that median falls sort of like toward the end of this bar right here. But if you add up 33.4 plus 18.3, you end up with something like 51%, I believe. So that's more than half of all the foreign-born cases that were diagnosed or progressed to active disease, within 9 years of arrival. And the CDC actually talked, and I thought, wouldn't it have more to do with somebody's age or some other underlying medical conditions? And in fact, it does. And that's really what it's about. Because as the population gets older, here, they've been in the U.S., let's say, 40 years. I mean, they're more likely breaking down with disease, not because they're foreign-born, but because they have some other underlying medical condition, perhaps related to age. And that's actually what it said in the CDC's report. But I thought it was also interesting that, this phenomenon was observed almost 20 years ago, and it hasn't really changed much since, at least not in that regard. So I thought that was interesting as well. Now, I don't know if the CDC is going to update their recommendations there, because again, that document's pretty well dated now, 1998. And another question that usually comes up, and I think somebody may have asked this last year, and I don't know, I can't remember if I showed this slide last year, but what happens is we want to know what, countries of birth of the foreign-born individuals. So, again, we're just going to focus in on the last 5 years in New Jersey, and that number is 1,307 cases, foreign-born. And you can see here that if you just look at the top 4 countries here, India, the Philippines, Mexico, Peru. All right, those 4 countries there account for right at 50% of all the foreign-born cases in New Jersey. Now, New Jersey is somewhat unique in this respect because if you look at the national data, you'll see that Mexico accounts for 20% of all cases nationally, and that India accounts for 8%. So it's almost as if, like, on the New Jersey data, you can see India and Mexico kind of switch spots.
Yeah, because a lot more Indian residents live here. Right, and Mexican residents. Right.
Right. Well, I'm just pointing out the obvious. Interestingly enough, on the national data, Philippines account for 13% foreign-born cases in the U.S. And it's actually the exact same proportion here in New Jersey, 13%, which was, again, nationally. The only country that did not appear in the national slide was Peru, but we obviously have a Peruvian population here in the U.S., in New Jersey. But, there's also this big piece here that's 25% all other. There was I think it was like 84 countries in total that are in the data. So obviously we couldn't, make a slice here for every one of those. So I thought, let me try to sort this by region. So again, this is the same data, except instead of using countries, we're just using geographical regions. Central Asia, East Asia, okay, accounting for half of all cases. Central and South America, 22%. The Caribbean, surprisingly, 11%. When you add up all those little countries there in the Caribbean region, it accounts for 11% of all the foreign-born cases in New Jersey, again, over the 5-year time period, and so on. Now, you can see Mexico, only accounting for some 8% of all the foreign-born cases over the time period.
Yeah.
That's serious.
No, here.
Oh, we're not. Oh. But Essex County.
Yeah.
And we talked a little bit earlier about the foreign-born population and the age demographic. When you look at all the cases that occurred among the foreign-born in New Jersey over a 5-year time period, you note that some 43% fell within that 25 to 44-year-old age group, which is somewhat unusual. So, but again, you have to know the denominator there, right? You have to know how the age is stratified in this population. So I took a look at that, and this is what you end up with. So you can see that the 25 to 44-year-old age group accounted for something like 43% of all cases, but they also accounted for close to 43% of the foreign-born population. So that's proportionate. So there's nothing unusual there. In fact, it was only, again, the individuals who were, wherever you see the red bar, higher than the blue, that's why you'll focus your attention to see if there's any age group that may be disproportionately affected. And so we saw disproportionately affected group was the equal to or greater than 65-year-old age group. Okay, and yes, the bar does sort of slightly go over the blue bar here, but when you work out the statistics on that, it's not statistically significant. Oops, let me find my, hold on. Well.
Oh, percent of the foreign-born population that's in that age group.
Having some trouble advancing the slide. I'm not sure why. I don't know if someone on your end can assist.
Can you click OK on the box? Do you see the box in the center of the screen?
No.
Okay, we got it.
I think we skipped some slides.
Yeah, like 3 of them.
I'm back. Hold on. Let me go back. Okay. So the next thing we look at is TB and HIV co-infection, comorbidity. I'm good. Or did I skip something? Stand by. Hold on, I'm lost now. Am I going forward or backwards? I should be going backwards. I'm sorry. I have no control over these slides right now. Shoot. I don't know, the cursor. Okay, let me see. Right there. Right there.
Frank, do you want us to forward your slides?
No, hang on. Let me. I didn't know. I thought somebody on your end was actually controlling it. I can't go backwards. Okay, that's fine.
Okay.
Okay, so TB HIV co-infection in New Jersey. This is 10 years, and you can see that the total number of cases is represented by the bar, and the red portion of that would be the proportion of the case patients who presented with HIV co-infection. And surprisingly, a very small proportion here at the end of 2014, we saw less than 5% of all cases. I think it was the total number was like just 14 cases that presented with co-infection. Now, the national average on that is, I think it's pretty low too, but it's closer to 7%. But again, we're dealing with small numbers relatively, so you can see just in the previous year, we're more closer to what the national average at least is or was. But the good news is that, at one point, and it's in all the literature, obviously, that, HIV is, the number one risk factor for a person progressing from latent TB to active disease. And, a lot of focus has been put in that area, and I think, you can see the results of that, here in New Jersey as well as nationally. Again, national data indicates some 6.7% of all cases reported presented with TB HIV co-infection. All right. The total number of cases that were reported with HIV co-infection over the last 5 years is 108. Okay? And what I'm showing here is that, almost 2/3, 1/3 split, foreign-born versus U.S.-born. But it's important to remember here that over the same time period, the foreign-born accounted for nearly 80% of all cases, but only 62% of the cases presenting with HIV co-infection. So it's actually the U.S.-born group here that's disproportionately affected by HIV. We can look at a graphic illustration of that here. When you just plug these numbers into a simple 2x2 table and calculate an odds ratio, you can see that the U.S.-born population had more than twice the odds of presenting with HIV co-infection versus the foreign-born. While there were 67 HIV positive among the foreign-born, that only represents about 5%. So another way to look at it, 95% of the foreign-born case patients were actually HIV negative. Looking at the U.S., let me see. Yeah, when we just look at that U.S.-born piece of that, it's, again, a pretty small number, 41 cases presenting with TB HIV co-infection over the last 5 years. When we just look at that by race ethnicity, nearly all of them, occurred in Black or African American case patients. look at the HIV, TB co-infection among the foreign-born, again, we're N equals 67, sorted here by region. To give you some idea of, again, we know that the vast majority of the foreign-born case patients in New Jersey are coming out of Central and East Asia, but the ones affected by HIV, are coming from different regions, okay, namely the Caribbean, in Central and South America, as well as Africa. But again, small number, 67 over 5 years. Another thing that we look at, both here in New Jersey and nationally, of course, is drug-resistant TB. Over the last 5 years, we saw that approximately, well, it fluctuates a bit, but I was going to say 8% of the patients are presenting with INH resistance. Of course, that's in 2014. And a very small percentage, only 1%, presenting with multi-drug resistant TB. And we see the same sort of data nationally. I think INH is up around 10% of all patients, but the multi-drug resistant TB, fluctuates somewhere between 1 to 2%, usually right around 1.5% of all cases. However, we have seen, when you just look at the numbers, you do see quite a bit of multi-drug resistant TB relatively. So we'll take a look at that in a second. When you look at the INH resistant cases, the real number there is 138, again, over 5 years, representing about somewhere between 6 and 8% of all cases. But the overwhelming majority of these individuals were foreign-born, presenting with INH resistance. Now again, something like 80% of all your cases are foreign-born. You'd expect to see somewhere around 80% of INH-resistant cases being there, but it's a little bit higher than to be expected. When you look at the multi-drug resistant cases, again, 30 cases over 5 years, nearly all of them were foreign-born, 97%. This is a slide that is also presented on the website. It shows all the counties and the number of multi-drug resistant cases in each county by year. You can see 30 cases over the last 5 years, between 2010 and 2014. The next topic is TB and corrections, and I know I had at least one question last year about, well, what about TB and corrections? And I'll tell you, this is why it really didn't make the highlight reel last year, but I'll show you the numbers and what we're looking at. So I ran this query on the data, and the question I'm asking, I'm looking at 5 years again. We know where N equals 1,665. The question is, was this person a resident of a correctional facility at the time of diagnosis? And the answer came up yes, 13 times. So there were 13 cases or case patients in the database that were a resident of a correctional facility at the time of diagnosis. Okay, that represents less than 1% of all cases reported over the time period. The national data indicates that 4% of cases are reported as being a resident of a correctional facility. So New Jersey is a little bit lower than the national average here. When you look at the type of correctional facility, this is what the categories are on our data collection. And you can see that more than half of them occurred in a state or federal prison versus local jail. And I believe the other, it involves like a halfway house, or there's some other categories, I can't remember exactly. Well, you can see that close to 2/3 of the cases occur in a state or federal prison in New Jersey. But again, very small numbers, less than 1% of all cases reported in New Jersey over the 5-year time period. Now that doesn't mean a whole lot, I guess, if you get a case that's difficult in a local jail or perhaps a prison, but again, these are the numbers. Just take another look, you'll see only 13 cases reported at the time of diagnosis in a correctional facility. I mentioned earlier about, and I read from the CDC's report in 1998 about children of the foreign-born, and we actually saw a little bit of a spike, I suppose, in TB meningitis and pediatric TB meningitis in New Jersey. Some of you all are aware of that, but folks out there who work with these case patients. But what we had was between January 2013 and January 2015, we observed 7 incident cases of pediatric TB meningitis, and these cases were occurring in very young children. Okay, as you can see where the median age was 1, with a range of 0 to 4. And they had some common attributes or some common traits here. They were all the U.S.-born children with foreign-born parents or guardians. And, you know, as these cases were being investigated, you know, we noted that there were delays in diagnosis by hospital emergency rooms and in a couple of instances by private medical doctors. Okay, so certainly a call for concern. But what we did observe additionally was that really when public health got involved, you know, the situation improved rapidly. Okay, in fact, I think the source cases for these children were identified, I think, in 6 out of the 7, where they found an adult in the home with active and infectious pulmonary TB. And that was all the result of contact, or I guess in this case, associated investigations conducted by public health. And in response to all of this, now, well, let me go back. The good news, obviously, is that we have not seen a case of pediatric TB meningitis since January of this year, so that's a good thing. Hearing music. Okay, but what we did was we wanted to get the message out, you know, again, it's that same message, I think, over and over. It's think TB, you know. There's really probably no better way to express that. So one of the strategies we had here was to try to reach these different associations and academies and try to get this message out to them. And I actually, back in June, was finally able to make contact with all these 3 different ones I've got listed here, namely the American Academy of Pediatrics, New Jersey branch, and we had a department-approved message that we drafted, and we sent that out to them. So now I don't know if they actually, hopefully they did do the email blast and or monthly newsletters. I don't, if there's some physicians out there who maybe are members of these organizations could let us know if they saw that. Now this was back in June. So hopefully that message is beginning to get out there. And, but we'll wait to get some feedback on that. Now, we're taking a look at all of this surveillance data, and I'm going to try to hurry up here, but, you know, it actually, you may say, well, what does this all mean to me? Well, you know, hopefully you're interested in the data and what the numbers look like, but it also affects the funding, you know, that comes to New Jersey. About half of the money, or the funding for TB control in New Jersey comes from the federal government, at least to the state health department. The CDC uses a funding formula, and you can see that it's largely weighted on this needs component. If you look at the top portion here, and this is related to, obviously, the number of cases, also some different aspects of those cases, foreign-born, so on and so on. Again, just to remind you when New Jersey sort of falls in the list nationally as of 2014, 308 cases, which was the 7th highest total count in the nation. The way these numbers fall, the way the CDC uses the funding formula, they look at 3 years worth of data, so just sort of try to mirror what they might be looking at there in Atlanta. I just put in the last 3 years. And going straight from the funding formula, total number of incident cases, 930 cases over the last 3 years in New Jersey. Some 68.6% occurred in U.S.-born minorities. 81.5% occurring in foreign-born. If you kind of group those together as population risk factors, you can see some nearly 90% of the cases in New Jersey, you know, meet that definition. All of these things should bode well, you know, for funding. They also look at the smear-positive pulmonary. Interesting to note, we talked about the sources of cultures and all of that. We looked at all the sputum and pulmonary, but only about 1/3 of the cases are actually smear-positive, pulmonary, and we see that pretty consistent across the country. HIV co-infection, 6% of all cases over the last 3 years. This is an area where I think we might be underreporting. Nationally, this number is closer to 15.3%, actually. I wrote it down. So, in fact, alcohol alone accounted for 11% nationally. So, we may be underreporting substance abuse here in New Jersey. I obviously cannot be certain. Another area is homelessness. Nationally, we see homelessness closer to 6% among TB cases reported nationally. Here in New Jersey, actually this number's up. We were as low as like 1.8%, I think, when I looked at 3-year data last year. So these two areas, I think, substance abuse and homelessness, is something that we need to take when nurses are doing those patient interviews. This is something we really need to look at, because although it's not a major element or variable in the equation, these two things actually do affect the funding that comes into New Jersey. So if we're underreporting, it's not a good thing. Multi-drug resistance, again, 13 cases over the last 3 years, 30 cases over the last 5 years. It's about in line with the national average. National average is 1.2% multi-drug resistant. And they also look at those B1, B2 notifications. Those are the immigrant refugee. And what did we say, Michelle? New Jersey was ranked like 7th in the nation. New Jersey gets mostly immigrants, but we do get a pretty sizable number. They don't really publish these statistics. We actually called, I think, last year, and they told us we were number 6 or 7 in terms of total number received by reporting area. But I suppose everything that's in yellow here it bodes well for us. The things there shaded in red are some areas where we want to make sure we're not underreporting. That funding formula also includes what they call a performance component. I don't know how important this is, but there were some areas that really insisted that these things be included. So I'll present those numbers there for you. Now, one thing that they don't talk about or look at too much or at all in the funding formula is, the follow-up of the contacts. But we do collect those data, and that's those TB41s that you all send in. And, there's a 2-year data lag on that. But this is the last report that we submitted into CDC back on August 15th of this year. And you can kind of take a look at the numbers. If you can see them there, there were 109 cases that were sputum smear positive. Again, about 1/3 of 308 cases. 320 cases that year. Again, about 1/3 were sputum smear positive. And then you can sort of follow the numbers down. If you look just in that first column, the number of contacts and the number evaluated, how many, actually 9 of those contacts were diagnosed with TB disease, 153 with latent TB infection, among which 125 started treatment and 94 completed. So I thought I'd share that data with you all just so you can kind of get an idea of what the statewide data looks like. The numbers may be surprising to you. You might think they're big, or you might think they're small numbers, but this is what we submitted. And it looks like I'm coming right up on the time, so I just wanted to say thank you to all of you all, the nurses out there, all the public health workers who work with the patients, the nurses who collect this information. I know sometimes we hound you for it, but unfortunately that's the thing we have to do. And I think that if we make an effort to share this data with you, both on the website, and if we can do it, maybe once a year like this, it would be more meaningful to you. I want all you all to know that every one of you all is part of the statewide surveillance team. Again, we only can enter the data that you give us. And so that's why we're always asking you for it to be as complete and as accurate as possible. So I'm sorry I can't be there in person, but again, thank all of you again. Eric?
Thank you very much, Frank, and thanks for your talk. It gets better every year. We're going to switch over now to Eric Cortez's presentation. And Eric is going to speak about a surveillance update in New Jersey. It'll take us just a moment to get the slides set for Eric. And if we can hold the questions for the end, I believe, we'll have a few minutes set aside for questions. Frank, will you be able to hang around and answer some questions at the end?
Yes.
Okay, that's great. Okay, just one moment for Eric. Yeah, if we could all please mute your phone, keep your phones muted during the presentation, that would be appreciated.
Good afternoon, everybody. I have taken, for many of you that have asked in the past, I have taken over for Francesca Esposito-Weir. So I am now the TB surveillance coordinator. So any surveillance questions you may have on top of any type of genotyping questions or laboratory questions can come directly to me. So this is my first introduction as your surveillance coordinator for the TB program. Oops. No.
Other way.
Other way. Here we go.
There you go.
Sorry. Recently, the only update that has come surveillance-wise has been concerns the sputum culture conversion. And of course, as we know, the culture conversion is the national objective and indicator. It's monitored within the National TB Indicators Project, NTIP, and that's actually collected on the report of verified case of tuberculosis, the RVCT. To many of you, you know it as the TB70. That's our national surveillance form for collecting TB data. The newest rules that have come through from out of Atlanta are that the sputum culture conversion should be documented for patients with sputum culture reported as positive and as positive only. And that's on the TB70, that's item number 18. The date of the sputum culture conversion is the date of the specimen collected for the first consistently negative sputum culture. That means there should be no positive sputum cultures after the negative culture results. Now, how that differs from the last time that this was changed was that the previous requirements for documenting the sputum culture conversion, which were published back in June of 2009, stated that the date should be at least 1 week after the last positive culture result. The now revised policy allows for a follow-up specimen to be collected at any time, so you don't have to wait the 1 week, and still have it eligible to be considered as the first consistently negative specimen. And that policy is effective immediately. Now, this was the only surveillance update to come out of Atlanta. Ever since I have taken over for Francesca after she left, I have fielded many questions about surveillance, and I just want to basically answer a few of the questions that have been posed to me very quickly since I don't have a lot of time. And this is just a few talking points. So the time between initial susceptibility results and final susceptibility results, which are items number 39 and 48 on the TB70, they must be equal to or greater than 30 days, which means if you're submitting an initial susceptibility result on September 1st, you should not be listing a final susceptibility result until the 30th of September or after that date. And I understand that many times you're collecting sputums one right after the other. There has to be at least 30 days in between to count as initial and final. Immigrant status, which is item number 35, that cannot remain unknown on your 70. If the status is undefined or illegal, it is to be checked as other status, please. In the initial TB70s that you submit, you can list unknown if this is the first time that you're meeting with the patient and you're gathering as much information as possible. However, going forward, and even to the final determination 70, it has to be changed from unknown. Same thing with HIV status, which is item number 26. It cannot remain unknown. There has to be either a negative, positive, not offered, or refused. So you have to actually ask the questions, please. Under item number 34, additional risk factors, that must be completed. If there are no additional risk factors identified, if you don't find any, if the patient doesn't tell you any, please check off none on the TB70. Item number 14, I've seen this actually a couple of times with pediatric TB patients. The item actually requests the country of origin for the parents. It's not their names nor their signatures. That is all I have at this point. If you have any surveillance questions regarding the 70, regarding genotyping, regarding anything to do with the laboratories, culture results, please feel free to call me directly. As many of you know, I have worked mobile in the past. I still continue to work mobile, even though I'm now the surveillance coordinator, which means the cell number that's listed there, you can reach me at any time, or you can send me a direct email. As many of you know, I contact you directly, and if need be, I will go to you and sit with you and help you with those 70s directly. These are just a few acknowledgements. I have, of course, Frank Romano, who's our program manager, Peter Fantasia, Ms. Galanowski, Jennifer Matta, who's currently on maternity leave, and all the people at the Division of TB Elimination. And of course, for any references, please feel free to use the website dictated there for the Centers for Disease Control, the TB surveillance dates and trainings. And I believe that's all I have. I'm going to open it up to questions if you have any.
Okay, so so we would like to open the floor up for questions now. We have a few minutes. I would like to remind people to please unmute their phone by pressing *6 and introduce yourself before asking your question. So do we have any questions from the room?
Questions for Frank and perhaps for Eric later on. But first for Frank, thanks a lot, Frank, for again, as usual, giving us a nice update on the state's TB picture. You know, these numbers are always very dry and sometimes quite makes us stare into the wall and just blankly kind of zone out. But you always make it a lot more interesting and with the interpretations and all that. You know, we've all heard about the trends in the U.S. and the state, and those trends have been kind of consistent over the last 5 years, decreasing numbers, foreign-born and all that. However, every time we look at these statistics every year, there are always certain things that we can pick up and perhaps ask ourselves, you know, what do we do about it? I think the ones that I can at least pick out here would be how the cases and the incidence rates tend to affect the young working person, the U.S.-born children below 5, the elderly, and the ones that get the MDR and XDR TB. Those seem to, in my head, that stand out. And begs the question, what do we do about them? Certainly, each community has a different pattern. Each county has a different pattern. And, you know, the state as a whole has a diverse group of counties. I think the question has to be asked by each of the county and local government people and ask themselves and take the initiatives to kind of address some of these patterns. And I don't know if we can encourage people, support them and all that in terms of addressing some of the problems. I think the young adult problem probably affects mostly students and people who come in for work legally. And so I think each county can figure that out. These are our problem areas, and how do we go about it? Has there been any effort to address some of these, or anything to highlight in terms of some of these pockets of incidents?
You mean in New Jersey or nationally?
No, in New Jersey.
Well, I mean, I think for me, you know, one of the things that, and maybe it's just my perception, I could be way off, but as I travel around the state and talk with folks in TB, I sort of get, you know, I assume everybody kind of is familiar with the data, both the national and the statewide data. But, you know, in conversation, you know, you start to get the sense that people really don't know what the numbers are. And I think for me, that's the starting point. You know, some people, like you say, may be more interested in sort of looking at the numbers and the trends than others. But I don't know how you can operate, you know, in a world where you're really not aware of the big picture, you know. So yeah, that's why I thought, you know, for me, you know, and I'm relatively new here in New Jersey, just having arrived here in 2011. You know, so I'm sort of at that point where I just want to get this information out, you know, in a repetitive way, or at least make it available more readily on the website, you know, so when people do have questions or are uncertain, they can sort of reference that and see where they are, you know, in their county or whatever it may be, township or municipality, you know, versus, you know, everywhere else, whether it be New Jersey or the nation, you know, say, hey, I'm seeing this. I wonder if this is unusual, you know, let me check. You know, I think that's the starting point. Beyond that, I mean, you know, unfortunately, what we're dealing with nationally as well as here in the state, you know, is just decreasing resources. As the case counts continue to fall, you know, I mentioned it. I hope everybody heard that number. Nationally, 2014 National Surveillance Report says there were 9,412 cases of TB in the U.S. You know, when you stick that into an equation, you know, you're dealing with pretty rare disease. Okay, there's 300 and something million people in the U.S. There's only 9,400 with TB. You know, I think, right. So you're dealing with, as that number continues to fall, you know, unfortunately, and we all saw this coming, Dr. Reichman and others, you know, predicted this, and so that's really the challenge right now, is we're trying to hold everything together. And it's called to sort of start new initiatives when you just, you know, plug in holes, basically, you know?
Well, no, that's precisely what I'm trying to point out, is it begs all of us who are involved in tuberculosis to kind of really, we're not collecting these numbers just because we have to. I mean, make use of them and act on them. You know, you see a certain pattern, you're seeing it in front of you. How can we use the limited resources better and target our approaches in TB control? And I think that's the message. And, you know, every locality can take the initiative. Nobody's, I mean, look at the numbers and look at your patterns and go ahead, act on them.
This is Karen Galanowski. I just want to respond to Dr. Ellen with two scenarios. One is the missed adults and pediatric cases that we saw from 2013 to 2015, the 7 children, and the sickness of out of those 4 of those cases had adults in the home who were sick, who went to the doctor. And it was never followed up. They had some had chest x-rays, but there was never any follow-up. So out of that, our state program has asked the Regional Training and Consultation Center to develop posters that could be available to put in private physicians' offices and ERs on the symptoms of TB. When somebody presents, when do you think TB? For both children and adults, and they're working on that now. And I was thinking, we haven't formulated how we're going to get these out to physicians and ERs, but I was thinking it should go from the local level out each of you will be given some that you could take to your doctors in the area who see family physicians, private physicians, those you know who have missed the cases, and the ERs to discuss, and also you could have a discussion when you take these out, and I think it could be done on a county-wide basis. The second thing that I've noticed over the last several years, but more so this year, is the number of foreign-born young people coming in on work visas. And as you know, there is no tuberculin screening or medical evaluation when you come over on a work visa. Some companies have taken it upon themselves after having cases diagnosed and then transmission occur in the work setting, but there's no global effort to provide this, and I really think that that's a message that should go back to CDC to say perhaps there needs to be some kind of screening prior to work visas being issued.
Yeah, well, I agree, but you know, if we wait for the CDC to act, it'll be 10 years from now when some guidance will come out, and I don't think anything is stopping us from reaching out and partnering with the community. You know where these IT training centers are. You know where the patterns are. Why not partner with the community?
Well, because they're big. They may be a financial center in Jersey City, but their headquarters are in Texas. Their headquarters are in New York City. They're big, and it would involve corporations, and it's much larger, from my perspective, than a local or even a state level opportunity. Certainly, when we go in and we do contact investigation and testing, we mention to their CEOs and healthcare that they probably could take it upon themselves as a policy to at least do a skin test as symptom assessment on all new employees, and some have done that from our efforts, but that's already after the fact. So, but the others, they're huge corporations, so it's been kind of difficult to figure out how you can implement a change.
Are there any questions from the folks who are on the line, please? Okay, so if there are no other questions on the line or in the room, if you have any questions that you think of, please contact Patty Woods at the Global TB Institute. Her email and phone number is on the screen. And for our follow-up, please go to this link that you see on the screen after this program and take the brief survey. The survey and your signature on a sign-in sheet are necessary in order to receive the 1.5 CME or CNE credits for today's program. And finally, the New Jersey Medical School Global TB Institute provides medical consultation services. You can call the 1-800-4TB-DOCS phone number with any questions requiring medical consultations in the Northeast region. And thank you very much. And you to thank all of our presenters today for sharing their experiences with us. And this concludes today's webinar. Thank you very much for your participation.